Alcohol use disorder, or AUD, is one of the most common substance use disorders in the United States, affecting millions of individuals each year. Although alcohol is legal and widely accepted in society, excessive alcohol use contributes to significant physical, psychological, social, and economic consequences. Alcohol use disorder affects not only the individual, but also families, workplaces, healthcare systems, and communities. This presentation examines the factors that contribute to AUD, how it is assessed and diagnosed, the effects of alcohol on the brain and body, and the evidence-based interventions clinicians use to promote recovery. Current research supports understanding alcohol use disorder through a biopsychosocial framework. Rather than having a single cause, AUD develops through the interaction of biological, psychological, and environmental influences. Biological factors include genetics, neurochemistry, and changes in the brain that occur with repeated alcohol exposure. Psychological factors include trauma, stress, coping skills, personality characteristics, and co-occurring mental health disorders. Social factors include family relationships, peer influences, cultural attitudes, socioeconomic conditions, and access to alcohol. These factors continuously interact, making comprehensive assessment essential when developing an individualized treatment plan. Alcohol use disorder remains one of the most prevalent behavioral health disorders in the United States. Recent national estimates indicate that nearly 29 million individuals aged 12 years and older meet criteria for AUD. The highest prevalence occurs among young adults between 18 and 25 years of age, although problematic alcohol use occurs throughout the lifespan. Because alcohol is socially acceptable and readily available, hazardous drinking patterns frequently develop long before an individual seeks treatment. Excessive alcohol use contributes to more than 178,000 deaths annually in the United States. Chronic alcohol use increases the risk for liver disease, cardiovascular disease, pancreatitis, and several forms of cancer. Acute alcohol intoxication also contributes to motor vehicle collisions, falls, violence, suicide, and alcohol poisoning. These statistics demonstrate that alcohol use disorder represents a significant public health concern rather than simply an individual behavioral problem. Alcohol is classified as a central nervous system depressant that affects nearly every organ system. Within the brain, alcohol impairs attention, memory, executive functioning, judgment, and motor coordination. Long-term heavy use may result in permanent neurological changes and cognitive impairment. Physically, alcohol contributes to liver disease, hypertension, cardiomyopathy, pancreatitis, gastrointestinal disorders, weakened immune functioning, and several cancers. Emotionally, alcohol is associated with depression, anxiety, irritability, impulsivity, and emotional dysregulation. Alcohol myopia theory proposes that intoxication narrows an individual's attentional focus to the most immediate and salient environmental cues while reducing awareness of competing information and future consequences. Rather than processing all available information, intoxicated individuals become cognitively short-sighted. This narrow attentional focus helps explain increased impulsivity, aggression, risky sexual behavior, impaired judgment, and poor decision-making. For example, an intoxicated driver may focus solely on getting home while failing to appreciate the dangers posed to themselves and others. Dr. Nicole Labor describes addiction as a shift in behavioral control between the brain's reward system and its executive control system. The midbrain, including structures within the mesolimbic dopamine pathway, is responsible for reward, survival, habit formation, craving, and immediate reinforcement. The prefrontal cortex governs executive functions such as planning, judgment, inhibition, decision-making, and consideration of future consequences. Repeated alcohol use increases dopamine activity within the reward system while simultaneously reducing the influence of executive control. Labor summarizes this interaction by stating that the midbrain, like a ninja, hijacks the abilities of the frontal cortex. For clinicians, this model explains why clients frequently continue drinking despite fully understanding the harmful consequences. Rather than viewing continued alcohol use as simply a lack of willpower, counselors should recognize that neuroadaptations weaken inhibitory control while strengthening conditioned reward pathways. Effective treatment should therefore focus on rebuilding executive function, developing healthier coping strategies, reducing environmental triggers, strengthening relapse prevention skills, and reinforcing behaviors that compete with alcohol use. Clinical assessment should progress from brief screening to comprehensive evaluation and diagnosis. The CAGE questionnaire, representing cutting down, annoyance by criticism, guilty feelings, and eye-openers, serves as a rapid screening instrument for possible alcohol misuse. The Alcohol Use Disorders Identification Test, or AUDIT, is a 10-item screening instrument developed by the World Health Organization to identify hazardous drinking, harmful alcohol use, and possible dependence. The Comprehensive Drinker Profile, or CDP, provides a more detailed assessment of drinking history, psychosocial functioning, family influences, environmental variables, and treatment needs. Assessment findings should then be compared with the DSM-5-TR diagnostic criteria. Alcohol use disorder is classified as mild when 2 to 3 criteria are met, moderate when 4 to 5 criteria are met, and severe when 6 or more criteria are present within a 12-month period. Alcohol use disorder is diagnosed using the DSM-5-TR, which requires that an individual demonstrate 2 or more of 11 diagnostic criteria during the same 12-month period. These criteria evaluate impaired control over alcohol use, social and occupational impairment, risky use, and physiological dependence. Examples include unsuccessful attempts to cut down, spending excessive time obtaining or recovering from alcohol, craving, failure to fulfill major responsibilities, continued use despite physical or psychological consequences, tolerance, and withdrawal. Once the criteria are identified, severity is determined by the total number present. 2 to 3 symptoms indicate mild alcohol use disorder, 4 to 5 indicate moderate, and 6 or more indicate severe alcohol use disorder. This dimensional approach helps clinicians determine the appropriate level of care and treatment planning. Alcohol withdrawal ranges from mild physiological discomfort to life-threatening medical emergencies. Early symptoms include tremors, anxiety, sweating, insomnia, nausea, increased heart rate, and elevated blood pressure. Severe withdrawal may progress to seizures or delirium tremens, characterized by confusion, hallucinations, agitation, and autonomic instability. Because alcohol withdrawal can be fatal, individuals with significant physiological dependence often require medically supervised detoxification before psychological treatment begins. Alcohol use disorder frequently co-occurs with depression, anxiety disorders, post-traumatic stress disorder, bipolar disorder, and certain personality disorders. Comprehensive assessment should determine whether psychiatric symptoms preceded alcohol use, developed during active drinking, or emerged during withdrawal. This distinction affects diagnosis and treatment planning. Treating only the alcohol use disorder while ignoring co-occurring mental health conditions significantly increases the likelihood of relapse. Integrated treatment addresses both the substance use disorder and the mental health condition simultaneously. Long-term alcohol misuse contributes to numerous chronic medical conditions, including cirrhosis, hepatitis, pancreatitis, cardiomyopathy, hypertension, peripheral neuropathy, gastrointestinal bleeding, and increased cancer risk. These medical complications influence treatment planning and frequently require collaboration among physicians, psychiatrists, and mental health counselors. Effective recovery therefore requires both psychological treatment and ongoing medical management. Evidence-based treatment begins with comprehensive assessment, followed by individualized intervention. Motivational interviewing, or MI, establishes rapport and helps resolve ambivalence toward change. Motivational enhancement therapy, or MET, builds upon this process by incorporating structured assessment, personalized feedback, and goal setting. Cognitive behavior therapy, or CBT, addresses maladaptive thinking, emotion regulation, coping skills, relapse prevention, and behavioral change. Additional interventions include behavioral therapy, family therapy, group therapy, psychoeducation, lifestyle planning, and relapse prevention. Because no single intervention is effective for every client, treatment should be individualized according to severity, readiness for change, and personal goals. 3 FDA-approved medications are commonly used to support recovery from alcohol use disorder. Naltrexone reduces cravings and decreases the rewarding effects of alcohol. Acamprosate helps maintain abstinence by reducing persistent withdrawal-related discomfort and supporting neurological stabilization following detoxification. Disulfiram discourages alcohol use by producing an unpleasant physiological reaction if alcohol is consumed. Medication is most effective when combined with counseling, behavioral interventions, and long-term recovery support. Treatment planning should consider family relationships, cultural values, spirituality, socioeconomic conditions, and recovery preferences. Family involvement frequently improves treatment outcomes by strengthening communication and support when clinically appropriate. Ethical practice requires informed consent, confidentiality, professional competence, respect for client autonomy, and avoidance of stigmatizing language. Cultural humility reminds clinicians that recovery is not a one-size-fits-all process. Some individuals prefer 12-step programs, whereas others may benefit from secular, behavioral, family-centered, or medically focused approaches. Alcohol use disorder is a chronic but treatable condition, resulting from complex interactions among biological, psychological, behavioral, and environmental factors. Comprehensive assessment, accurate diagnosis, Individualized treatment planning, evidence-based interventions, medications when appropriate, and long-term recovery support significantly improve treatment outcomes. Although recovery is rarely linear, individuals who receive comprehensive, integrated care can achieve meaningful and sustained improvements in functioning and quality of life.